Good afternoon, everyone. Welcome to Medical Grand Rounds. Thanks to those of you who have come here to meet us in person. You can enjoy a nice light lunch. It's a pleasure to see you here in person today. And welcome to everyone who's online. Thanks for being here as well. Before we get started, just a brief reminder to please enter your questions at the end of the presentation. Please enter them in the chat and please answer a brief survey that will be sent to you after the presentation. Before we get started, I'd like to take a moment to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. It is a pleasure to introduce our speaker today, a new colleague of ours in the Division of Cardiology, Dr. Judy Luu. Welcome, Judy. Dr. Luu is originally from Calgary. She completed a combined MD PhD with a doctoral focus on using cardiac MRI in patients with ischemic heart disease. After completing her adult cardiology residency at the University of Manitoba, she went on to complete a fellowship in women's heart disease and health in Los Angeles with the world-renowned expert, Dr. Noel Bairey Merz. She has recently also completed advanced training in health research methodology and clinical epidemiology under the mentorship of Dr. Sonia Anand from McMaster University. As a woman's heart health cardiologist with expertise in cardiac MRI, Dr. Luu will be developing a dedicated clinical research program to improve the diagnostic and therapeutic management of women with heart disease here at the MUHC. She also currently serves on the Executive Steering Committee of the Canadian Women's Heart Health Alliance as co-chair of the Advocacy Working Group. Thank you, Judy. It's a real pleasure to have you here today.
Okay, thank you so much, Nadia, and thank you everybody for joining at home. And today I'd like to present on an area that's actually very passionate to me, and I hope that there are some points that you will find useful to use in your own practice. So I have no disclosures except that I'm also learning with you. So to begin, I always like to start off with a clinical case. We have here a 50-year-old Black female. She presents to your practice with chest discomfort that started 2 years ago. It occurs about 2 or 3 times a year, and it's now increased in the frequency and intensity over the last several months. She endorses epigastric pain that is sharp and tight in quality, and it's radiating to her back. This is associated with tingling and paresthesia in her fingers, and it's worse with exertion, but sometimes it could also occur at rest, lasting for several hours of the day. You can see this her past medical history and her current medications. Her vitals and her physical exam, as well as her lab work, you can see is pretty unremarkable, and EKG is also normal. So my first question to the audience in terms of the screening assessment, considering everything that you learned and know to date, how would you rate her risk for future cardiovascular events? You can think about it in your head, but people here, who would choose A for low risk, B for moderate risk, C for high risk, and D for I am not sure, I'd like some more information, please. Okay, so a mix between B, and D. So thank you, everyone, and we'll get back to this case. So the objectives for my presentation today are threefold. I'd like you to understand the burden of cardiovascular disease in women, and we'll be reviewing the sex and gender differences in the screening, diagnostic, and management of women's cardiovascular care with a more focus on the screening and diagnostic part. And at the end, I will highlight some strategies that we can improve cardiovascular care pathways for women. So to begin, cardiovascular disease remains a major cause of death for females in Canada. And this was taken from the latest Stats Canada literature and data that I derived these graph from. And you can see for the last decade, cardiovascular disease, combined cardiovascular disease, so that's stroke, heart disease, aortic disease, et cetera, is only second to malignant neoplasms in terms of leading causes of death for females. And what's more alarming is when you look at specific populations, so you can see comparing males to females between the premature cardiovascular disease age group, so that's anybody under the age of 65. Can you see my mouse there? Yeah. You can also see that there is a growing trend in terms of cardiovascular disease deaths, mortalities for women who are between the age of 45 to 54, and a stagnation in that decline in women between 55 and 64. And when you contrast that to men, there's actually a appropriate decline in the cardiovascular mortality. And globally, this is also the same. So cardiovascular disease is on the rise, and we look at the World Health Organization mortality data in these high income countries, you can see that there is a stagnation in that decline of cardiovascular death, and that in countries like the United States and Canada, so very affluent countries, that the mortality rate for women is also increasing. And then finally, of all the causes for cardiovascular disease, ischemic heart disease remains the leading cause amongst all the cardiovascular disease. So on top of rheumatic disease, stroke, hypertension, et cetera. And this is in the majority of regions, including our own in North America. So as a person, I'm a very logical and pattern-oriented person. And so for me to better understand the barriers and disparities in the pathways to cardiovascular care for women, I like to think about it in terms of this framework. And I'll be walking you through this framework in terms of the risk assessment and screening. And for the presentation, I will focus more on the first half, and later on, if there's ever a second part, I will focus on the therapeutic management for women. I will be sharing 10 key messages or takeaway points that I'd like, as snapshots for you to just to walk away and to incorporate into your practice or your learnings and studies after this talk. So first off, traditional cardiovascular risk factors are not the same in men and women. What do I mean by that? So while we have the same traditional risk factors like diabetes, hypertension, diabetes, hypertension, dyslipidemia, there are differences in the impact of these risk factors when we compare men and women. And for instance, when you take type 2 diabetes, when you compare it to men, the presence of diabetes in a woman confers an more increased risk of ischemic stroke, and women are 3 times more likely to experience adverse events compared to a man. That same goes to smoking. So you can see that compared to a man, women who smoke have a 25% higher risk of cardiovascular events, and that's independent of other risk factors. And young women who do smoke have a 7 times higher risk for myocardial infarction and compared to men of the same age. And then hypertension is actually the biggest risk factor for cardiovascular disease globally. And it's just so poorly optimized in our affluent countries because a one-size-fits-all for hypertension really doesn't apply and is actually detrimental to women. So according to our guidelines, a threshold of 120 systolic blood pressure is what we aim for. But more and more large observational studies are showing that 110 millimeters of mercury systolic is actually the threshold for women to experience heart attacks, heart failure, et cetera. And so you can see that the risk of stroke with each level of hypertension, so 120, 130, 140, is 2 times larger for a woman than it is a man. And my second message of the day is that females have specific risk factors for cardiovascular disease across their lifespan. And so we know that there are multiple emerging novel risk factors that women can encounter across a reproductive lifespan, and we call these female-specific risk enhancers. They're risk enhancers because these historical elements, they cannot be modified like your lipids or your glucose levels, but instead they mark an indicator or mediator for future cardiovascular disease. And these female-specific risk enhancers, you can see, exist across her lifespan, and they actually play a very significant role in determining the woman's cardiovascular risk profile in front of you. And so it's important when you encounter a woman and you're doing a risk assessment to identify these elements so that you can impact along her trajectory and intervene with primary preventive strategies such as statin initiations. And what do I mean by adverse pregnancy outcomes? So I refer to these pregnancy complications you see here, these 6 listed. There's actually many more than that, but these are the 6 more commonly studied that can occur in as many as 20% of pregnant women. So they're actually quite prevalent. And you can see it ranges from preeclampsia, which is the most common study and most prevalent, to things like low birth weight or preterm delivery, defined as under 37 weeks. It's actually unfortunate, though, that many cardiovascular disease specialists or medical specialists are not aware of these adverse pregnancy outcomes, and few do incorporate these detailed pregnancy history into their risk assessment of women. And average pregnancy outcomes, or APOs, are associated with premature cardiovascular disease. So in med school, we're taught that the treatment and cure for preeclampsia is to deliver the baby. But this is actually quite misleading because average pregnancy outcome actually portends an increased risk for future heart disease for that woman in front of you. You can see from this retrospective cohort study performed out of Ontario of over 1 million women, they showed that women who've had a history of maternal placental syndrome, so things like preeclampsia, gestational hypertension, they had a doubled risk of premature cardiovascular disease, and that goes up to 4-fold if it's complicated by things like fetal growth or intrauterine fetal death. And what's more alarming is that the mean age for her first cardiovascular event, so presentation to the hospital for angina, heart attacks, etc., actually occurs at 10 years after, so 38. So if you have a woman in front of you who's had an average pregnancy outcome at 28, she could present as early as 38 years old for her first cardiovascular event. And asymptomatic women with history of preeclampsia actually have evidence of subclinical cardiovascular disease. And so in this study, they looked at asymptomatic women who compared to women who did not have preeclampsia and looked at the presence of coronary artery calcification. And you can see here that the coronary artery calcification actually develops earlier in women, about 5 years earlier than women who don't, and that this excessive risk is actually most prevalent in the 45 to 50-year age group. And that importantly, despite having, more modifiable cardiovascular risk profiles, their Framingham risk score, so the traditional cardiovascular risk score that we use to estimate risk, poorly underestimates their overall risk profile. So these women, despite having subclinical disease on the Framingham risk score, do not meet the threshold of greater than 10% to initiate preventative therapies like statins. And so adverse pregnancy outcomes, I want to reiterate, are not benign. And this diagram nicely illustrates it. You can see here that, preeclampsia has a 4-fold increased risk for heart failure, as well as risk for ischemic heart disease. And it's the whole gamut of the average pregnancy outcomes. So if you can walk away and just recognize that if you've had colleagues, family members, friends who've had a pregnancy complication, on top of, despite having no other traditional risk factors, she is at risk for future cardiovascular events. Now, moving on to other female-specific risk enhancers, you can see that earlier menopause is also a major one. And so what do I mean by earlier menopause? The average age for menopause in a woman is around 50 years old. And so anything under that is considered earlier. You can see from these models that there's a linear relationship between the age of menopause with your risk of incident cardiovascular disease, with that of coronary heart disease and stroke. And so the clear message is that the earlier the onset of your menopause, the higher the risk of your cardiovascular disease in the future. And they've shown, when they looked at menopause, age of menopause as a continuous variable, that every year of decrease in your age is associated with a 3% increased risk of incident cardiovascular disease. So this is an important slide to take away. And our new guidelines only somewhat address these average pregnancy outcomes and earlier menopause. You can see to your left, this is the latest Canadian Cardiovascular Society 2021 guidelines on dyslipidemia, and they have one little section about how they recommend a screening for a woman with a complete lipid panel if she's had pregnancy complications, recognizing that she has increased premature cardiovascular disease after that incident event. In the American guidelines, the latest one is in 2019, and you can see that they've astutely call it CVD risk enhancers, referring to things like preeclampsia and premature menopause, really to say that if you have these risk enhancers, it will play in your decision, perhaps swaying you to initiate statin intensity, initiate statin therapy if she's in the low to moderate, gray zone. And so something for you to consider. And I like to show this slide because there's now emerging sex-specific imaging biomarkers for cardiovascular disease. This is work that I did with Dr. Natalie Diane in a recent editorial that we submitted to the CJC, looking at the duality of screening mammographies. So every woman in Canada and across the world, if they have appropriate programs, are entitled to having screening mammography for early detection of breast cancer. And what they now know is that the incidental findings of breast arterial calcification, so there are these long linear-like railway tracks that are medial artery calcifications are actually indicative of future cardiovascular events. So this is juxtaposed to what we see in terms of intimal calcification, which is more classically associated with coronary artery disease or plaque formation. And in this editorial, we describe nicely, and I encourage all of you to read it, is that the reason why breast arterial calcification or BAC is gaining traction is that it is linked to cardiovascular risk factors like diabetes and hypertension. And more studies are now showing that there's increased risk for mortality, stroke, and heart failure. So these previously thought to be incidental findings, not routinely reported on your mammographies, actually portends worse prognosis for the woman in front of you. And we hypothesize that the presence of these breast arterial calcifications in small to medium-sized arteries are perhaps indicative of microvascular dysfunction. And that really could be the mechanism that's driving the heightened cardiovascular risk in these women. So in the new future, leveraging this knowledge and this experience, we will be looking at ways to understand the mechanism driving women who have BAC by using cardiac MRI. As you know, here with Dr. Friedrich as the director, myself as the director of research, we have a world-renowned center for cardiac MRI, and we'll be better understanding these women and studying them here at the MUHC. So back to the audience, I'd like to ask you and the audience at home of the 90-something people and people here, how often do you ask for the reproductive history on your patient encounters? You don't have to put your hand up, but you can just. So A, I always ask. B, I often ask. C, not often, seldomly. Or D, I've never asked for this on history. Okay, thank you for your honesty. So my third key message or takeaway point is that really, as our understanding of cardiovascular differences in sex and gender deepens, I want to stress that a generic clinical approach is no longer adequate to properly assess a woman's cardiovascular risk profile. And failing to recognize these female-specific risk enhancers and these risk factors throughout her lifespan, throughout her reproductive lifespan, could really lead to an underestimation of her future cardiovascular profile risk. And so it's leading to missing crucial opportunities to initiate primary preventative strategies. Okay, so let's go back to our case study of our 50-year-old Black female. You can see that on additional information that somebody wanted in the back here, this is her reproductive history. This is what I ask pretty often. About 99% of my patient encounters of women or females, I ask their age of menarche, their menopause, hormone history, pregnancy history, and then the common, most prevalent adverse pregnancy outcomes. You can see here that by definition, she does have a history of earlier menopause, and she also has a history of preterm delivery in her second pregnancy at 35 weeks. And so over the course of a few months, she continues to return with this cardiac symptoms, this angina. And as you can see, multiple cardiac investigations are ordered by her specialist or cardiologist, including a nuclear test, transthoracic echo, coronary CT scan, and an exercise treadmill test. And you can see they were essentially all normal with good exercise capacity. So at this point, I like to poll the audience. What would you do now? Would you A, suspect that this is non-cardiac chest pain, reassure and recommend follow-up with her family doctor? Would you B, order additional alternative cardiac investigations? We can answer for B here. Would you C, refer to internal medicine colleagues to rule out potential causes, pulmonary or GI, like GERD, reflux? Would you E, go ahead and add a beta blocker and follow up in 2 or 3 months? Or would you E, I'm not really sure what to do next, I'd like more information? Okay, we got answers for B, some E. Thank you. So now let's move on along our framework to the diagnostic section. So the fourth key message is that women may present differently than men for ischemic heart disease. And you can see that they may present with varied pattern and distribution of cardiac symptoms that are distinct from that of men. And this figure really nicely summarizes the most common as well as the additional or prodromal symptoms described by a woman. You can see that in the majority of men and women, they often do present with chest pain as their presenting symptom for ischemic heart disease. But that importantly, a woman can also present with things like fatigue, weakness, shortness of breath, sleep disturbances, and all of these non-specific or atypical, we call them before, might delay the evaluation diagnosis for that woman. And I want to relay that even for me as a women's heart health specialist and a cardiologist, it is very difficult, to have this very pattern distribution, across the spectrum of women. It's difficult for the healthcare provider and our team to interpret the pain symptoms and to appropriately manage for her. So you're not alone, and I'm learning as well. There's also a racial and ethnic component or variation in your cardiac symptoms. And in the Women Ischemia Syndrome Evaluation, or the WISE study, which is the body of literature that has really supported a lot of our understanding now of women's heart disease, you can see here that in a population of women with suspected coronary artery disease, Black women actually report more stomach symptoms and are less likely to report chest symptoms compared to their white counterparts. And in this figure, I want to illustrate, I want to clearly show or make clear that while chest or upper body or stomach symptoms were not predictive of adverse events, but a low score on the typical symptom cluster. So, typical, and I'm going to go through that, just to review, but typical in terms of exertional chest pain, relieving with rest, relieved with nitro, being low on this symptom cluster actually is associated with adverse mortality events independent of other risk factors. And that's not the same when it goes for their white counterparts who also present with low, who also present low on the typical symptom cluster. And so this really suggests that the presentation of atypical symptoms in Black women may be a barrier to appropriate clinical diagnostic and treatment regimens. And I started this because I often teach this to my trainees when I'm on service with them, is that a woman's cardiac symptom is only atypical when compared to a man. So when we look at the Diamond Forrester, which is where I think we all know the Diamond Forrester, what we're routinely taught in med school and residency, the classification of chest pain for an individual, you can see that their data was derived from a very small cohort, 43 patients, 81% of which are males. You can see here that the typical substernal chest discomfort precipitated by exertion relieved by rest within 10 minutes with nitroglycerin is really only found in 17 patients. And that atypical, when you have two of those three factors, only 6 patients. You can imagine how many women are in there if there are only 81% of males, and that the numbers are even more abysmal when you look at the non-anginal and the asymptomatic cohort. And when they extend the extension of their data, there's actually in this table here, a large proportion of people with atypical angina who have evidence of non-obstructive disease. So D- is for people who have less than 50% disease. And you can see here in the atypical population, as much as 1/3 of these patients have non-obstructive disease. And so typical angina is really only good for obstructive coronary artery disease. And then finally, I want to show again, so from their ongoing work, looking at, this was the seminal paper in the New England Journal of 2,400 people who then they used to derive their classic table that we refer to often. And you can see here that 71% of those study participants were male. And so I quote, this classification, although highly subjective, has several strengths. First, it is practical, being easily learned, remembered, and applied. And second, it is relevant. So taken from their paper, I think in today's time, in 2023, with all that we know, this is no longer relevant and no longer, I think, ethically appropriate to apply to our patient population. And they've also shown that typical angina across the board of male and females is a barrier to accurate diagnosis and treatment of ischemic heart disease. So when they looked, when they compared treatment and outcomes of patients without chest pain to those with chest pains, they found that patients who actually lacked chest pain, so the atypical presentation, actually received less effective care across the board and also had worse outcomes across the board. And this is regardless of whether you're a male or female. So my fifth key message, taken directly from the 2021 latest American Heart Association guidelines for chest pain, is that, I quote, non-cardiac is in and atypical is out. So please don't use atypical to describe. I get a lot of referrals like, this woman has atypical chest pain. It's only atypical because it's compared to a man. Just describe her symptoms. She has fatigue. She has shortness of breath, whatever it is that she may have, or the male in front of you. But atypical is really misleading, and it may actually lead in delays of appropriate screening, diagnosis, and treatment. And so please use non-cardiac if suspected. So now I'd like to focus on what I've been alluding to before, is really this different paradigm. And the sixth key message is that no obstructive coronary disease does not mean no ischemic heart disease. Because for decades, our primary focus when we manage patients has been really to, manage patients with angina has been really to verify coronary atherosclerosis with flow-limiting coronary epicardial disease. And in recent years, you can see from this figure that that has shifted with more understanding, more imaging modalities, more awareness. And on the stable coronary syndrome side, you can see that obstructive disease pairs with its counterpart, ischemia with no obstructive coronary arteries. And that on the other spectrum, in the acute coronary syndromes, you can also have conditions, what we call MNOCA, so myocardial infarction with no obstructive coronary artery disease. And so what is INOCA? My apologies for my team who have heard this before, but INOCA really is when you have symptoms and signs of ischemia, but you have no evidence of obstructive disease on invasive CT coronary angiogram or when you do FFR. And it's actually very common. You can see from this figure that among patients who were referred for clinically indicated coronary angiograms, that 2/3 of women and as much as 1/3 of men have non-obstructive coronary disease, and that this trend is actually increasing for both males and females across over the years. And when you look at a patient population of people who have suspected INOCA, coronary vasomotor dysfunction is common. And so if you've never heard of the term coronary vasomotor dysfunction, it's a constellation of what I refer to, or the literature refers to, as the presence of microvascular dysfunction or microvascular angina, and or the presence of vasospastic angina or coronary vasospasm. You can see that it's very common. Patients who have suspected ischemia have up to 60 or 90% of them can have a sequelae of microvascular or vasospastic angina. So they do have real disease pathology despite having normal testing. And that takes me to the seventh major point here, is that a negative stress test does not rule out the presence of coronary microvascular dysfunction. You can see when they compared the invasive gold standard of coronary function testing in patients who have INOCA with that of our routine modalities, so exercise stress testing, dobutamine, SPECT, etc., that the sensitivity and specificity for these modalities to detect coronary microvascular dysfunction is very poor. It ranges in the as much as 40% sensitivity or 60% specificity. So really, a negative stress test does not mean that the patient in front of you does not have real pathology, does not have real disease. And when we look at women who have INOCA, there's actually a systematic underestimation, again, of her overall cardiovascular profile. And researchers who use the WISE cohort in women who have chest pain, and they've demonstrated that our commonly used risk scores, like the Framingham risk score, the ASCVD, which is mostly used in the United States, they do not accurately assess. And in fact, they tend to underestimate the risk for cardiovascular disease in these patients. You can see from this figure, when you look at the predicted and the observed rates of events in these patient populations, that these risk scores really underestimate the risk. And so I urge you to not apply this if not possible, and to really put everything together, what you know in front of her, female specific risk factors, her symptoms, etc., when making that appropriate assessment. Should I admit this patient here, this participant? And so women with ANOCA have poor prognosis. And so again, from the WISE data, compared to asymptomatic patients, women who have ANOCA have up to 6 times increased risk of major adverse events, and that's independent of traditional cardiovascular risk factors. And she also has a 3 times increased risk for repeat angiography and hospitalization. And again, there's also racial and ethnic disparities that exist for Black women who have ANOCA. And we've shown in the WISE cohort, specifically for Black women who have ANOCA, there is a 1.5 times increased risk for long-term major adverse events. And this more than doubles for cardiovascular mortality at 10 years. And that's striking. This is independent of her age and independent of other traditional cardiovascular risk factors when you compare Black and non-Black women. And my next message is that perhaps education campaigns and awareness may be one of the answers for improved outcomes. Because when we contrast the same cohort of women who had obstructive disease but recruited from academic and university centers, we can see that the long-term MACE and cardiovascular mortality are actually similar between that of women, Black women and non-Black women. And specifically, despite Black women having relatively higher burdens of cardiovascular disease and lower socioeconomic positions compared to the non-Black counterparts, this disparity that we saw with women with ANOCA diminishes or becomes non-significant. And so we postulate that Black women who have obstructive disease that are treated in academic or university centers perhaps experience less racial and ethnic discrimination and also receive more appropriate guideline-directed therapy. And so one of our next chapters of my ongoing research will be to look at this very topic here. And that takes me nicely to the Power Hub, which is an ongoing project that I'm doing in collaboration with the Courtois Cardiovascular Center program, so led by Dr. Natty Giannetti here and Dr. Matthias Friedrich. And the Power Hub stands for Pathways to Cardiovascular Care for Women in Ethnic, Racialized, and Remote Communities. It was actually a smaller component of, in the spring, there was a major CIHR grant initiative. I unfortunately didn't get it, but some very astute colleagues here, Dr. Isabel Maham, did get it. And so kudos to her for such a major, tremendous endeavor to improve women's health overall. And in this specific project, I'm going to be looking in collaboration with Courtois CVC to better define the women's cardiovascular risk assessment with a better screening tool, specifically in collaboration with Black cultural community partners in Montreal. So I've partnered with the Jamaica Association of Montreal to look at this, and we'll be recruiting almost 800, 900 women. We'll be doing initially in the Black community, so of Black ethnicity, but it'll be branching out to as many of the minority populations we can, and the cultural populations that we can in Montreal. And the other steps are later down, but we'll also be, planning to build a better registry for improved recruitment of these women into clinical research. And so on the topic of education, there's actually, so that's what's being done locally, and that's just a snapshot of what I'm doing. There's a lot of researchers in the community locally who are working, Dr. Louise Pilot, Dr. Nathalie Dallaire, like I mentioned before, but on a national level, there's a lot of educational campaigns that are going on too, and I'd like to share a couple here. So on the Women's Heart Health, the Canadian Women's Heart Health Alliance, which is a network of multiple healthcare researchers, partners with lived experience and allied health professionals across the country. And they are launching a women's heart health curriculum directly in the cardiology residency. I'm going to be one of the presenters here. And so the idea is to integrate concepts of women's cardiovascular health early on rather than later on, so specialty where I learned it in my fellowship. So if we can intervene earlier, that would be the ideal goal for these cardiology trainees. There's also, if you're not aware, and I use these resources regularly, there's a QR code for you to scan here, multilingual resources that addresses some major key messages for women's cardiovascular health. So we have them available in 17 different languages, including Arabic, Inuktitut, Vietnamese, Portuguese. And so if you're running into trouble of trying to educate the patient in front of you, I urge you to you just go on WearRight Canada and guide you to these multilingual resources to find better ways to convey that message to your patient so that they can also advocate for themselves. And I use these pretty much on a regular basis in my practice. And then finally, if you have any children that are in the high school range, there's also a campaign. We developed a curriculum for high school students to look at sex and gender differences in women's cardiovascular health. And we're in now the dissemination phase to launch these across the country, including Quebec. And we have it available in French and English. And so I'd be curious to know if any of you have heard these in your family household as well. And finally, on an international level, there are a lot of efforts to better understand how we can treat women who have non-obstructive coronary disease. And I'd like to showcase just one here. This is the Warrior trial. And what they're basically looking at in a cohort, they're still recruiting, but of up to almost over 4,000 women who have INOCA and evidence of confirmed on invasive or coronary CT, that when randomized to intensive medical care or guideline-directed medical care, and what I mean by intensive medical care is to include statins, to include ACE inhibitors, and also to include a baby aspirin. And their hypothesis is that these women, all comers, if they have symptoms and no evidence of obstructive disease, that actually initiating these therapies will reduce incidence of first cardiovascular event when followed up at 3 years. So this study's been ongoing for a few years now, so please stay tuned. I think in the next couple of years, we will have a lot of data to help guide us in terms of how we treat these patient population. Okay, so finally back to our case. The woman who presented with chest pain, she was appropriately put on statins for her risk of adverse pregnancy outcomes. She was like I think some of you had astutely pointed to, I would identify her as a moderate risk or for future cardiovascular event. One could say that her race ethnicity being Black also portends increased poor prognosis, so maybe moderate to high risk for cardiovascular disease. And so she was put on anti-anginals and a statin. But then she returned with persistent symptoms. And so at that time in Cedars-Sinai, we decided to proceed with non-invasive imaging using stress cardiovascular magnetic resonance. And I just like to show these pretty images. You can at the top here, this is just images of her left side of her heart and the thicker muscle, and then the right side of her heart with the less thick muscle. And these are just the short axis and the 4-chamber view. You can see that she has normal function and normal size. But when we apply the method of contrast with the stress agent, so here it's adenosine, to look at the perfusion bed of her myocardium, you can see there's a dark area in the subendocardium, so inside our heart muscle, and that when we quantitate it, corresponds with what we call a myoperfusion reserve of less than 1.84, and that's indicative of coronary microvascular dysfunction. And also important that she doesn't have any late enhancement, which is evidence of any scar on her imaging. And I'll just quickly showcase this slide for people who would like to do more reading later after this, is that the management of INOCA, we don't have any guidelines because there's not enough randomized controlled trials or robust clinical trials to guide this, but there are expert consensus. And so really the cornerstone of everything we do in cardiovascular medicine is really to focus on lifestyle modification. So if a woman's in front of you and suspected to have some, chest pain in the absence of obstructive disease or normal stress testing, you can definitely begin by doing, aggressive discussion with her for aggressive lifestyle changes. So that's improving her nutrition, getting on a good exercise program, smoking cessation, etc. And then I'm really aggressive when I manage the risk factors overall with women who I suspect to have INOCA. And so my threshold for hypertension is often for a female if she can tolerate less than 110. And then my threshold is also very low to initiate statin therapy if if her lipids are elevated, we have much more robust now. Dr. Schneiderman can convey this, but if ApoB is elevated, again, I also pretty quick to start a statin therapy on these individuals. And then finally, depending on what you suspect, and this is another talk for another day, but depending on if it's microvascular vasospastic angina, there are medications to modify her symptom burden, and then also for appropriate follow-up. And so I'll end with a couple slides here that there's a lot of opportunities for education. We did a survey looking at cardiologists across the country in the United States. And you can see here that, there are a lot of cardiologists or specialists who, while they are confident in managing patients who have ischemia, so we asked the question, how confident are you in managing stable patients with INOCA? And across the different tenor levels, so early career, mid-career, late career, and the total, you can see that about a third of cardiologists are very confident, and that overall about 70% are confident. But you're not alone if you're in the audience, being that 1 out of 3 cardiologists who's not confident in managing patients with MINOCA. And I would say that even me, who I see these patients routinely, there are sometimes I have doubts in terms of what I'm doing. Is this cardiac? Is this non-cardiac? And it can be quite frustrating, both in the acute and stable setting. And then this slide here looks at when we ask the question, how often do you prescribe the following for your INOCA patients? And so, like I said, there are no right now really robust clinical trials, but there are a lot of literature that does support the potential use of statins, and particularly ACE inhibitors in patients who do present with coronary endothelial or vascular smooth muscle function, so entities of coronary vasomotor dysfunction. And you can really see here that when we look at the ACE inhibitors here with my arrow, that as much as 70%, so that's quite an alarming number of cardiologists, so specialists who are supposed to recognize these patients, do not prescribe ACE inhibitors or angiotensin receptors. And so that is a point of education opportunities for improvement that I see in the future in terms of how we can address these barriers and disparities for cardiovascular care for women. Okay, so finally, I'd like to put up this concluding slide that really, to alter the trajectory of cardiovascular care and outcomes for women will require a unified collaborative effort with the right timing and the momentum. And so it won't just require awareness campaigns or educational advocacy in silos, and concurrent, robust scientific clinical evidence that's ongoing as we speak. And then it's really about a change in policy. So my mentor from Cedars-Sinai, Noel Bairey Merz, she had made this statement that had really stuck with me, is that, in terms of, and I'm going to relate it to cardiovascular disease and specifically in women, but, she said that I can continue to see a patient and treat a patient in my individual practice, and that's going to impact the lives of, 1 to a couple thousand. But if I'm able to do robust clinical trials and to show that there is evidence to improve these outcomes for these women with medications or therapies, I'm then going to eventually able to change policy. And when we change policy, we impact the lives of millions. So it's going from individual to thousands. The goal is to change millions of lives, particularly women. I'll leave men to my other colleagues. Okay, so those are the 10 key messages or takeaway points, and I hope some of them will stick with you, if at all. So, but yeah, thank you so much. Let's thank my incredible team also. Thank you.
Thank you, Dr. Judy Luu. Thank you for that wonderful presentation, and really congratulations for everything you've brought to McGill and everything that you've all the work that you've done and the publications you have in the literature advancing this very important topic. You can enter your questions in the chat, but I'd like to actually start. Can you tell us a little bit about Can you tell us a little bit about hormonal therapy, postmenopausal hormonal therapy, yay or nay, based on the literature and your experience?
Yes, absolutely. So, okay. Yeah, so hormonal therapy it's a good question. It's like always a tough area. So in my training, there are very clear. So what I mean by hormonal therapy is there's different formulations. There's estrogen tablets. Oh, so yeah, there's like estrogen formulation, patches, vaginal formulations. And I think there's a really, in my mind, a clear indication in the role for hormone therapy in the appropriate woman. So if a woman goes into premature menopause because she's had surgical removal of her ovaries due to cancer treatment, or for whichever reason goes into ovarian failure and unclear cause, and she's 40, there's a clear role to be on estrogen therapy to bridge that gap of when her body should have naturally produced its own estrogen. And then after, in the perimenopausal, postmenopausal period, there's data that within the 5 years to mitigate her symptoms, there's also a role for hormone therapy. But certainly after, 10 years, and I do see some women who are on hormone therapy in my practice that are on estrogen still, I stop it because the risk at that point and the benefit at that point is limited. There are, treatments for, vaginal dryness, mood changes, etc., that don't require estrogen hormone therapy. And so I just have that discussion on an individual basis. It's certainly an area of ongoing research. So what I say now may not be that case many years later, but it's certainly something to bring up. If you see someone in your practice and she's like on estrogen tablets, I definitely think you should address that if it's not the right. And the other indication is if you have severe osteoporosis in the postmenopausal period. Okay. So Sasha Bernaski asks, in the Kaplan-Meier, the Kaplan-Meier, could diabetes explain some different cardiac symptoms in Black versus white women? I thought diabetic patients tend to have atypical symptoms, but maybe I'm wrong. You may get to this, but atypical angina men were more likely to be small vessel disease. And apologies using atypical. It's okay, Sasha, I forgive you. Yeah, so the diabetes, so we did look at that, and in this WISE cohort, it was not a predictor or confounder in terms of the adverse cardiovascular events. But I agree, diabetes is certainly a major risk factor and should not be avoided. Yes, so I don't spend much time on it. It's a whole lecture on its own, but you can kind of see some of the data that I was alluding to, that the people who had atypical, there is a proportion, about a third, even as early as the 1980s with the Diamond Forster data, that people who have atypical chest pain tend to, as much as a third, can have non-obstructive disease. I don't think atypical more likely implies a small vessel disease, because, I don't want to use atypical, but atypical may be non-cardiac. So I don't want you to walk away thinking that all atypical shortness of breath, fatigue, etc., means cardiac. It can be non-cardiac, and in some cases it's appropriate to refer for, a lung assessment or GI assessment. So it's really on a case-by-case basis.
Sorry, it was just in a way a point of clarification. So in the particular case that you presented, the diagnosis of INOCA was made after you did the stress MRI. Is that correct?
Yeah, so this case, I in a roundabout way. So actually, for me, especially if you don't have cardiac MRI or if you don't have invasive coronary function testing, what I often do is diagnose empirically or clinically. So I have a strong suspicion that her chest pain is real or cardiac symptoms are real, and there's absence of positive, negative stress testing. You don't always have to refer for a CT coronary angiogram or angiogram. In her case, though, if you saw in the testing, she had a CT coronary angiogram that didn't show any obstructive disease. So in the US, everybody gets a CT coronary angiogram. Here, I would say seldomly refer to invasive coronary angiogram because, it is invasive. There are risks that come with it. It's very safe here, though, to be honest. But what I often do is treat empirically, and if there's ongoing suspicion, then I will refer to advanced imaging modalities.
It just doesn't seem very practical, to be honest. Right now at the general, the wait time for a regular echo is a year. So trying to get an MRI on a patient who may have atypical chest pain, sorry, I shouldn't use that word, has symptoms that you're not sure what they are. You're the cardiologist, so you're suspecting heart disease, but what about the person who's not the cardiologist? Should they be referring all these?
Yeah, that's an excellent question. So for the audience, it's a question of, given our limitations and access to resources, not in just Quebec, but across the country, who don't have, let's say, advanced CMR or easy access to angiogram. What do you do when the symptomatology is hard? So actually what I do, and it's what we did at Cedars-Sinai too, is to treat empirically. I do what I call a diagnostic and therapeutic trial of nitroglycerin. If the patient's symptoms improve nitroglycerin, then I'm more likely to think this is probably cardiac, likely perhaps ANOCA. And then what's important to me is if it does improve, it opens up a whole toolbox of other antiangiogenics that I can use. So nitroglycerin, oftentimes patients have headaches. But if they respond to it, and I explain very clearly, I take away the disclosure about I know it's meant to be used for acute settings too, but if it does improve, then, we can use amlodipine, calcium channel blockers, verapamil, alpha beta blockers, carvedilol. And so there's a whole toolbox that opens up. So I don't think you're incorrect. You don't need to be a cardiologist to treat patients. You can also treat it empirically as you would as an internist, and I'm an internist too. So
Thanks very much.
yeah, you're welcome. Yeah, that's actually Javad. For people at home, it's just a really great comment. I didn't have enough time to share this data, but we recently showed using the Courtois CV signature data in women who've had a history of earlier menopause that there's on advanced tissue characterization on cardiac MRI, there's evidence of elevated T1, which is indicative of what we hypothesize as diffuse fibrosis. And so if you know that pathway of diffuse fibrosis leads to potentially diastolic dysfunction, cardiac remodeling, and then it then leads to that phenotype of HFpEF, so heart failure with preserved ejection fraction that we also commonly see in women. So we're just diving a bit deeper into better understanding the mechanisms of all these female-specific risk factors. Thanks, Javad.
There are many
maybe.
questions and comments, a lot of very favorable comments. So I'm going to invite you to read all this. Let's do a few little rapid fire here type of questions. Any role of a sleep apnea in, cardiovascular disease in women? Any comments on that?
Where did that come from? That came from,
I don't remember now.
Shumita Pamidi. Yeah, thank you for your comment. So I've actually had a really interesting discussion with one of my colleagues at Concordia who studies sleep apnea. And actually, we're going to be looking to implement questionnaires looking at sleep apnea. So even just as simple as a stop bang or neck circumference in the Courtois. If people, I've been putting a lot of buzz. We use a lot of collaboration with the data set. So yes, right now I don't know fully about sleep disturbances, insomnia, and sleep apnea and its role in cardiovascular disease, but I'm sure that there is a marker to accelerate cardiac aging or remodeling in this patient population. So we will be looking into that further too.
Perfect. Dr. Rosenblatt wants to know, is the findings in pregnancy, are they causal or are they markers? So is there damage to the CVS during pregnancy that leads to future heart disease, or are there common predisposing factor that lead to both?
Yeah, so that's an excellent question. So there's actually two leading hypotheses or theories, and it's actually the chicken or the egg. It can be the egg and it can also be the chicken. So the way that I describe it is that pregnancy is really a nature windows into a woman's future cardiovascular profile, and it's a stress test. A woman should be able to carry a pregnancy up to term normally if there were no underlying disease pathology. So one of the hypotheses is that when a woman experiences an average pregnancy outcome, it's actually an indicator that she has subclinical cardiovascular risk factors, whether that be diabetes, endothelial dysfunction, untreated hypertension, or some other genetic marker that then predispose her to have that event, that preeclamptic event, and then therefore along the trajectory to cardiovascular disease. The other hypothesis is that average pregnancy outcomes, and specifically preeclampsia is the most well studied, is that it can also be causal. It can trigger, pro-inflammatory cascades, damage to the endothelium, and therefore also precipitate cardiovascular disease. So I think both hypotheses and theories are very valid, and there's research ongoing to study both of these mechanisms.
Dr. Schiffman wants to know about aggressive BP lowering in ANOCA. You want a systolic blood pressure less than 110, but this would surely lower the diastolic blood pressure to less than 60. Is there evidence of harm if diastolic blood pressure, which is responsible for perfusion of the coronary circulation, is less than 60?
Yeah, that's an excellent question. I'm not a hypertension expert. I think this is more of an individual level, I think, and it's certainly an ethnic, racial component and a body habitus confounding effect to it too. So I think for women, I'm not sure if 60 is, because if for my diastolic blood pressure, it's actually quite low. It's like, it is around 60, 70. And so I imagine that if we were able to study on a precision medicine level, different racial ethnics, Asians, et cetera, that bringing it down to 60 may be appropriate. Anecdotally in my practice, I'm not so much concerned about the diastolic blood pressure, even the systolic. I'm actually more concerned about their symptoms, and I treat it the same way I do with heart failure. We're pushing heart failure blood pressures down to in the 80s, 90s. I really ask the patient, how do you feel when your blood pressure is low? Are you having lightheadedness, dizziness, fainting spells? Are you weak and you can't function? Or can you, at a systolic of 110, 120 or lower, do you feel well? And if they feel well, then I just keep going. If they, at 130 or 120 feel like this is not good for me, then I just stop. So it's more on an individual level. And so it's not so much about the number for me. Once I get that target, it's how they feel and their side effects to the medications.
Okay, we have 2 minutes left. Dr.
Okay.
Doss wants to know, ApoB and LPA, is it the same for ANOCA as it is in obstructive coronary disease? Are you looking for those values and treating them the same way?
Yeah, so I am looking for those values. I actually am across the board of general cardiology. So the latest guidelines recommend that every individual in their lifetime should at least get an LP(a). And the way I use it is it's risk modifier. So if everything else is normal and they have a few risk factors here and there in that woman, it helps me to paint the picture better. It's not like a slam dunk like LP(a) means statin. It just really helps me, the woman in front of me, if these markers, if these lipid profiles are positive, then I tend more to treat. My threshold is lower to treat in this patient population who do have symptoms, because we've shown that if you have ANOCA and you have symptoms, that alone increases your risk of events. Yes, in Courtois, they do measure LP(a) and ApoB, and so we are looking into the correlation association of these biomarkers with that of clinical imaging endpoints, as well as in this patient population.
Fantastic. I'd like to end with a comment that Luis Pirata is bringing up, that November 7 is Women's Heart Health Symposium. Can you just put a pitch in for that, please, for us?
Yeah, absolutely. So it's November 2nd with the astute scientific committee. So Dr. Natalie Diane, Dr. Luis Pilote, and Wendy Ray from the Women's Health Initiative. There's going to be some really exciting speakers, myself included. We're talking about the gamut of women's cardiovascular health. I'm talking specifically on women's health in the immigrant population. So come for that. I'm a refugee immigrant by background, so I'll be sharing a lot about the experiences and how we mitigate disparities for people from minority populations.
How do people register for that?
There has been an email that's been sent out, but we will keep sending out, bombarding you to register. So it's been sent out in the Department of Medicine, and there's also I think individual emails, cardiology division sending it out. So yeah, please come and join.
So I'd like to invite Dr. Luu to continue to read and the chat and answer questions and look at the really great comments in the chat. So for those of you who are online and your question has not been answered, we'll ask Dr. Luu to continue to answer them in writing in the chat. We will have to close the formal presentation because it is 1 o'clock. Judy, Dr. Luu, thank you so much for a really terrific presentation. I learned a lot, and I'm sure our audience did. And I think it's the type of presentation that you should come back to see us annually to give us updates.
Sure.
So thank you and congratulations on the terrific work you're doing in this field. Thank you for being here today. Thanks everyone for joining us. Have a wonderful afternoon.